uh, liver analgesia. So Dr. Rachit Duggal is postgraduate from Tata Memorial Hospital, and he further did the fellowship in pain medicine from Martin Luther University, and fellowship in critical care also, and fellowship in the diabetes from Royal College London. So he has worked in prestigious institutes like Fortis, Apollo hospitals, and presently running a pain center and medical care center, also working with the past Grecian women.
Thank you, ma'am, for the wonderful introduction, ma'am. Today I'll be talking about the latest guidelines and latest techniques we use in liver analgesia. As you know, pain is a really difficult thing for the gynecologist to tackle, and once the patient stops cooperating because of pain, it is a very difficult thing for the gynecologist to make a normal delivery. So, my first slide is, what are the beneficial effects of relieving labor pain? Why we want a labor analgesia? First of all, it relieves pain, anxiety and fatigue. And secondly, decreasing the biochemical thing is it decreases the catecholamine release, and which also helps in increasing the uteroplacental blood flow, and it prevents hyperventilation and eliminates fetal acidosis. If patient is in a lot of pain and the labor is prolonged, you might get a fetal acidosis, and the Apgar score is reduced. Now, what are the basic? There is two stages of labor, and in first stage of labor, mainly the pain is visceral pain, and is from A delta and C fibers. And in second stage, it is mainly somatic pain. In first stage of labor, the pain is basically from T10 to L1 sympathetic plexus, and in second stage, it is basically from S2 to S5. Now, what are the basic modalities what we use? First of all, non-pharmacological methods of relieving pain. Basically, a lot of people they suggest hydrotherapy, warm water, everything. It doesn't work actually. The only non-pharmacological method which is working is TENS therapy. It gives you around 10 to 20% of relief during labor pain. And the modern approach is they say you go for a psychoprophylaxis, and basically it is mainly training the patient in relaxing and breathing exercise. As Dr. Vinita ma'am told, the patient has to be relaxed and tabhi ko push karega. Then only the patient is going to push. So now we come to the pharmacological methods. First of all, pharmacological methods mein, the main thing is we give a IV systemic opioid. So we have, nowadays we use fentanyl, but the problem with fentanyl is it causes respiratory depression of patient as well as the fetus. Second is Remifentanyl. Nowadays it is a drug of choice for IV medication for liver analgesia, because Remifentanyl is very ultra short acting. It starts working in just 1 minute, and the maximum duration of action is around 6 to 8 minutes. And the main thing is onset is very early. It is ultra short acting. You give Remifentanyl and within 1 minute the patient is telling, I am relieved from the pain. And the dose is between 0.5 microgram per kg. That's not a big dose. And generally we use it in a ECA pump, that is patient controlled analgesia. I will be talking later in this session. So the maximum dose we give is around 30 to 40 microgram as a bolus dose. It starts working in 1 minute, and it doesn't cause much of respiratory depression, and it's eliminated in 6 to 8 minutes, and it is very, very effective. It's very, very effective and with the least side effects. Ketamine we use, but it causes hallucinations, so patient will not cooperate after giving ketamine. Tramadol everybody must be using, but it doesn't cause much of pain relief in second stage of labor. So basically, the crux is for systemic use, for IV use of liver analgesia, Remifentanyl is the drug of choice. Next slide is about the inhalation analgesia. So IV work now is inhalation analgesia. In inhalation analgesia, basically we used to use antinox, that is oxygen and nitrous mixture, but it also doesn't work in second stage of labor because it's a lot of pain. So the latest studies show that sevoflurane inhalation in the concentration of 0.8% is acceptable and effective and provides very superior pain relief. And the problem with this is it causes a lot of sedation. So the patient will not push and copulate. So the limitations are drowsiness, unpleasant smell, and high cost. So when we talk about IV medications, it is Remifentanyl, and inhalation, the drug of choice is sevoflurane for inhalation analgesia. Now, the methods which we use, which are the neuraxial blocks. These are the most popular methods and with the least side effects. First of all is epidural methods. Every gynecologist must be asking for their patient, they must be asking for epidural analgesia, and you are all familiar with that. So in epidural, there are two methods. One we give is an intermittent bolus and continuous infusion. There is a myth among us all that continuous infusion will give a better pain relief, but it is not that. Intermittent bolus technique is better when we use epidural analgesia. Next is patient controlled epidural analgesia, that is PCEA, and last we use combined spinal epidural analgesia. In PCEA, nowadays we are using computer integrated background infusion and computer integrated PCEA and program intermittent epidural boluses. Now again I am stressing on that using of intermittent bolus is better than using a continuous infusion. Now what is the new about this is we use low dose of epidural regime, low dose epidural. Earlier we were using bupivacaine in the percentage of 0.2 to 0.25%. That was tradition. Now we use the method we use is MLAD and MLAD. That is minimal local anesthesia dose and minimal local anesthesia volume. So in that we decreases the concentration of the local anesthetic so that we can increase the volume. So bupivacaine we use in the dose of 0.0625. The normal bupivacaine which is available is in the percentage of 0.5%. But we have to dilute it to a solution of 0.0625% and a maximum dose which we use is 0.125%. That is extremely diluted form. In that form we can use it in a greater volumes and that will work better. There is another drug which you must be familiar with is LEVOBUPIVACAINE. Bupivacaine is a very popular drug, but we are now using LEVOBUPIVACAINE and ROPIVACAINE. These two drugs, they causes less cardiotoxicity and less neurotoxicity as compared to bupivacaine. Now, in addition, we have to use, in addition to the local anesthetic, we have to use opioids. The opioid of choice for epidural analgesia is fentanyl, and we have to use in the dose of 2 microgram per ml in the infusion form. That we have to use in an infusion form. Now, nowadays we are using patient-controlled epidural analgesia. What we do is, there is a machine with PCA pump. In that, we just insert the epidural and fill the dose of the drug, and we give a remote to the patient. The patient will be controlling herself. Whenever she has a pain, the patient can press the PCA pump, and the bolus dose of the epidural will be delivered to the patient. But there is a crux. We have to provide an interlock time so that the patient might not keep on pressing and she might take a larger volume or the larger doses of the drug. So there is an interlock period. In this PCA pump, and it is really very effective. Why? Because it gives a feeling of control to the patient. It gives a feeling of control. Patient feels that I am controlling my pain myself, and immediate access to additional dose or epidural. Suppose we are in a setup, in a government setup or in a private sector where there is a lot of patients. So when the patient is having pain, she has to tell the nurse is going to call the doctor is going to come and give the dose. So in that there is a delay time and the patient loses trust in the doctor. So there is immediate access to an additional dose of epidural. It causes less motor blockage and lower drug usage and lower the staff workload. So the latest thing what we use is, it's not only epidural analgesia. What we use nowadays for labor analgesia is combined spinal and epidural analgesia. You must be shocked to hear we are giving spinal also, spinal intrathecal drug also in labor analgesia, but the dose has to be modified. So as per the latest guidelines, combined spinal epidural analgesia is considered the best newer technique, and it is really known as walking epidural. What are the main advantages? It causes immediate and rapid onset of pain relief. It gives an instant pain relief to the patient, higher ambulatory potential and lower drug use. So what are the drug regimes we use in combined spinal epidural for labor analgesia? Initially we can give an intrathecal dose. We can tell you an anesthesiologist, or we can give a dose of Fentanyl, 25 to 30, maximum dose is 50 micrograms intrathecal fentanyl with a spinal needle, and at the same time you can give a dose of ROPIVACAINE 1 milligram to 2 milligram. I am not talking about ml. 1 milligram is equal to 0.2 ml. The ROPIVACAINE is available in 4 ml ampule and it is 0.5%. So of that 0.5%, if you have to give just 0.2 ml, that is 1 milligram. You can give a dose of 1 to 2 milligram of ROPIVACAINE intrathecally through the spinal needle. And same dose can be used with ROPIVACAINE, and ROPIVACAINE if you are using, the doses is a bit higher, 1.5 milligram to 2.5 milligram. It's 1 milligram is equal to 0.5 minutes, half ml of 0.2% of ROPIVACAINE. It has to be followed by continuous infusion of ROPIVACAINE or LEVOBUPIVACAINE with a fentanyl infusion of 2 micrograms per and that has to be given to the epidural set. And after in combined spinal epidural, we don't give a bolus dose of epidural, we give a continuous infusion after an intrathecal dose. Now, nowadays we are also using computer integrated PCA pump. PCA is patient controlled epidural analgesia. In this, you can see we have a infusion pump. Infusion pump is attached to the computer device, and this computer device will direct the infusion of the drug. So how does it work? It adjusts the background infusion rate according to the amount of the local anesthetic used in the previous hour. Suppose you are giving a bolus dose, you have given a higher dose 2 times or 3 times, then the computer will automatically calculate the doses and it will give an integrated infusion. Second is program intermittent epidural boluses. It's same like a PCA, it's just like the same of the PCA. Now what if the patient refuses for an epidural or an intrathecal and a labor analgesia? Even the gynecologist will give this block in the first stage of labor. It's a paracervical block, and in second stage pudendal block and perineal inflammation. Now this is another device which is latest. This is known as EPIA devices, acoustic puncture assist device. To avoid accidental intrathecal puncture or the dural puncture with the epidural needle, we use this device. This is an acoustic device in which there is if you can see, there is a graph and there is a needle attached to this device. Once you insert this needle and start inserting this needle, there will be an acoustic and a visual signals it will give a high frequency sound. As you enter the epidural space, it gives a maximum resonance of sound, and then you can see the graph also. There is a peak of the graph when you enter the epidural space, and that tells you that you are in the epidural space and you don't have to enter the needle further. Now we also use ultrasound assisted epidural catheter insertion. It helps in visualizing the depth of the epidural space and positioning of the catheter. Last